MGravis. The first couple of slides are going to be your outcomes and the QSIN outcomes as well, so I'm going to go ahead and click through those. Okay, this is the first actual slide of content. So we're going to talk about myasthenia gravis today. Myasthenia gravis itself is part of the chronic neurology lectures. It's an autoimmune disorder, and what it does is it affects the myoneural junction, and its symptoms is basically varying degrees of weakness of the voluntary muscles. As far as the pathophysiology is concerned, normally there's a chemical impulse that precipitates the release of acetylcholine from the vesicles on the end of the nerve. And what happens then is the acetylcholine attaches to the receptor sites on the motor end plate of the nerve, and that in turn stimulates the muscle to contract. So you need to have that acetylcholine to attach to the receptor sites so that you can trigger the nerve to contract, okay? In myasthenia gravis, what happens is that there are antibodies because it's an autoimmune disease, and it attacks the receptor sites and damages those receptor sites. So acetylcholine can't get a good handle, it can't grab a hold, and so therefore the impulses, voluntary muscle impulses, are impacted because there are fewer actual receptor sites that are still available for the acetylcholine to attach to. About 90% of the people that have myasthenia gravis will have an anti-acetylcholine receptor antibody in their system, so we'll see that. And then about 80% of the people who have myasthenia gravis will also have some impairment of their thymus, and about 15% will actually have a thymic tumor. So you can look at your slide, which kind of summarizes what I just told you, okay? The next slide is going to also show you another picture of this. Okay, so if you look over there on slide A, you can see that that's a normal acetylcholine receptor site, okay? And you can see there's lots of little receptors, and so that acetylcholine can get connected really well. But if you look over to the slide to your right, or in other words, B, then you can see those X's, and those are all receptor sites that have been attacked by those antibodies and basically are no longer available to the acetylcholine, okay? This leads to muscle weakness, and we see this muscle weakness especially in the areas of the face and throat, okay? And I mentioned earlier to pay close attention to the thymus. Remember that about 15% of the people with myasthenia gravis will also have a thymic tumor, and about 70% that may not have a tumor will still have hyperplasia changes. And the reason that the thymus is so impacted is because the thymus is an organ of the immune system. Okay, as far as clinical manifestations, I've listed those on here on this slide, so I'm not going to detail them. I want you to be aware that these patients are very medication dependent. When they wake up in the morning, that med has worn off. So very, very first thing in the morning, you're going to see them be weaker. However, they're also going to follow very shortly and start taking their medications. You can see some dysphonia, which I put on there, I think. Yeah, I did, which is actually impairment of their ability to speak. It's a voice impairment. There is a bit of a hereditary issue involved here, and about 10 to 20% will have a family history of MG. Now, this always intrigues me because it makes good common sense to me that that medication wears off overnight and so they're weaker in the morning. But I have seen numerous English questions ask when is the best time to schedule activity for a patient with myasthenia gravis, and they consistently say that the correct answer is in the morning. So I've given some thought to that, and the best that I can figure it out is they're saying that because they're saying that after they get up, they don't mean immediately afterwards, but after they get up and they take their medicine and their medicine kicks kicks in, that's when it's the best time to schedule activity. It's important when you are scheduling activity to think about when those medications are going to peak, and also to work on managing the activity so you don't potentiate increased muscular weakness. Okay, as far as clinical manifestations, again, I've listed these out for you. Some things that I do want to mention to you is that typically the ocular muscles are the first problem that we'll see whenever someone starts to develop myasthenia gravis. The two things that are most common are either double vision or drooping of the eyelids. And remember, ptosis, which I have on there, Ptosis, is just a fancy word for saying that that's drooping of the eyelid. Most patients will experience weakness of the face and throat along with generalized weakness, and about 90% of them will have involvement of the eyelid. What you kind of see then, because of that weakness of the facial muscles, is a patient who presents with a very bland facial expression. The weakness of the throat, which impacts the larynx, is what causes the dysphonia, and that's the voice impairment. This is also affecting the throat area that results in an increased risk for choking and aspiration. They also experience generalized weakness that affects all of the extremities and the intercostal muscles. So when the intercostal muscles are affected, we see a decrease in vital capacity, and we can see this patient progress to respiratory failure. Something to remember about MG is that this is a disease of muscle weakness only. There's no loss of sensation, and there's no loss of coordination. As far as checking their ocular movement, remember to assess the eye movements, do the look up, look down, look right, look left, look at the nose, those types of things. From a diagnosis standpoint, it's based primarily on history and physical exam first, and then after that we follow up with lab tests. We can continue on with a variety of tests as we're continuing to narrow down and make sure that we're on target with a diagnosis of MG. One of the things that blood tests will show is the acetylcholine receptor antibodies of patients who have generalized MG. We also see EMGs that are sensitive to single fiber EMGs as a way of confirming MG. The tensilon test, I want to talk a little bit about that. What we do with the tensilon test is we inject the client with edrophilium, and I'm going to spell it for you, which is EDROPHONIUM. I'm going to spell it for you again. EDROPHONIUM, which is the generic name for tensilon. It is an anticholinesterase agent. And so if we give that, if we inject that, and we see increased muscle contractility after the injection, that's indicative that the patient indeed does have myasthenia gravis. After about 30 seconds of giving the medication, the facial weakness and the ptosis should resolve for about 5 minutes. So when you see that immediate improvement of the muscle weakness after giving the medication, it's a positive test for MG. One of the problems with tensilon, one of the complications, is bradycardia. So you always want to make sure that you have atropine on hand, okay? Other symptoms that you might see besides bradycardia are also sweating and cramping, okay? Now, the tensilon test is maybe a little bit passé quite honestly, and instead we're able to do a better job with the blood test that we're able to give, okay? As far as collaborative care is concerned, the primary thing that we give is an anticholinerase, which I've got it up here. It's the pridoxyamine, which a trade name for that is mesinon, okay? And what it does is it enhances the function at the neuromuscular junction. And remember, go back to that first slide I talked about, and the problem has to do with the acetylcholine has limited numbers of receptors that it can attach to. And if that acetylcholine cannot attach, then it cannot trigger the muscle contractility. Okay? So the use of the pridosinamine is the first line of therapy. It provides symptomatic relief, and the way that it works is it inhibits the breakdown of the acetylcholine and increases the relative concentration of available acetylcholine at the neuromuscular junction. We start them out on a dose, and we gradually increase that dose to reach a maximum dose. Some problems that we see along with that are problems such as anxiety, insomnia, headache, seizures, diaphoresis, increased bronchial secretions, and you can see how that might be a big problem here with this patient who already has generalized weakness, tachycardia, hypotension, nausea and vomiting, which I think we see with everything, diarrhea. We can also see increased salivation. So if they're going to have an increased amount of saliva, can you see where that's also a problem as we see that generalized weakness in that neck and throat area? We also can give corticosteroids, and I gave you some examples, as well as some immunosuppressants. Okay. If we're giving the immunosuppressives, we typically want to do liver enzymes and white blood cell counts. Okay. As far as further collaborative care, we can utilize plasmapheresis and IVIG. Plasmapheresis we talked about way back at the beginning of the semester when we talked about immune, and we use that to treat exacerbations, which is what a myasthenic crisis is. And you already know what plasmapheresis is, so I'm not going to repeat that for you. The reason that we give IVIG is to give them passively give them antibodies. And then a thymectomy is something that we can look at. The removal of the thymus gland results in an improvement in the majority of the patients. Sometimes we'll see a partial or even a complete remission. Remember that we just don't up and take the thymus out. First off, the thymus has to be showing some level of abnormality. It could be the hyperplasia or it could be an actual tumor, okay? So if the thymus is normal, don't take it out, okay? I gave you some specific information in regards to when a thymectomy is considered or indicated, and that's on the slide. One of the biggest things that we have to worry about with our patients with myasthenia gravis is the respiratory status. The respiratory status is most significant because we see both the generalized weakness and also the weakness in the throat and neck area, and this can lead to respiratory failure. We have problems with poor airway clearance because of an inadequate cough and gag reflex. Sometimes we need to move ahead with intubation and mechanical ventilation. Something to remember is that if we put that patient on mechanical ventilation, then our cholinesterase inhibitors are stopped and then gradually started after the patient is pulled off of mechanical ventilation, okay? Our goal here is to protect the airway, okay? The difference between myasthenic crisis, and cholinergic crisis. This slide gives you kind of the patho of it, what causes it, and the next slide gives you the symptoms, okay? You do need to know the difference between myasthenic crisis and cholinergic crisis. You will have test questions on it, okay? So when someone presents, we need to figure out which of these crises that they're in. A myasthenic crisis is also, you could think of it as an exacerbation disease. disease process, okay? And it's caused by some kind of precipitating factor. That factor could be inadequate medication, or it could be some other type of complicating comorbidity, such as an infection, okay? You're going to see the increased skeletal weakness. Remember the bulbar signs, so that weakness that weakness in the throat area, the difficulty with swallowing, okay? They can have dyspnea. One way that we know that this is a myasthenia crisis is we see an increased strength after we give them administration of anticholinesterase medications, okay? The patient is typically placed in an ICU because they need to be monitored. It's very likely they might get put on mechanical ventilation. You can do the tensilon test, which all that is the administration of the tensilon, and see whether or not there's improvement. That helps to give us a clear picture that we're dealing with myasthenic crisis. You're going to want to monitor G's, electrolytes, INO. This patient likely will need NG feedings. Something we do want to avoid, however, is the use of sedatives, because that's only going to aggravate the hypoxia that we see. With cholinergic crisis, this is because of an overdose of the medications, okay, for the most part. Okay, you could have it because of a remission. You can also see it after we've done a thymectomy and we're still trying to manage the medications, and we get kind of off base there. You're going to see some of the same symptoms. And then over here, I've put on there some specific effects on the smooth muscle that you would want to be aware of, okay? Remember, we can use the tensilon injection to see the difference between the two. The next slide is going to just give you the symptoms. Okay, I'm not going to review these because they're very nicely laid out for you. You'll notice that I've also got a couple of things bolded and highlighted. So you can see for myasthenic crisis, you're going to see an increased blood pressure and you're going to see tachycardia. For cholinergic crisis, you're going to see a decreased blood pressure and bradycardia, as well as come down to the bottom of that list underneath the cholinergic crisis. And you see I've also got nausea and vomiting and abdominal cramps and diarrhea highlighted as well. In between there, you can see some commonalities between the two, okay? You do want to know the difference between myasthenic crisis and cholinergic crisis. You want to know the reason for it, you want to know what you're going to do about it, and you want to know the symptoms. The next slide just runs you through some processes as far as nursing management. For assessment, you're going to look at fatigability. You want to see what parts of the body are affected. How severely is the person affected? What are their coping mechanisms? What is their ability to manage their daily function? And you also want to always be assessing the gag reflex. Or from a respiratory standpoint, you want to look at the respiratory rate, the depth of the respirations. We want to know what their O2 sat is. You may want some ABGs. We want to be watching for any signs of respiratory failure. Nursing diagnoses, you can look at several of those. I'm just going to toss a few out. Something along the lines of ineffective airway clearance related to intercostal muscle weakness and impaired cough and gag reflex. You could have something like impaired verbal communication related to weakness of the larynx, lips, mouth, pharynx, and jaw. Our planning is to return the muscle endurance, avoid complications, and maintain their quality of life, because this is a chronic disease. There's not really a cure for it. Some things to think about under nursing implications is to recognize that when that patient's admitted with an acute myasthenic crisis, they often will also have a respiratory infection going on as well. So airway and breathing quickly becomes a priority. We need to look at nutrition. Remember, they've got that weakness in that neck area, so we could see some problems with intake. If they not close their eyelid, we may need to tape the eye shut at bedtime to prevent corneal abrasions. Stress the importance of taking meds on time and teach energy conservation. Okay? From a nursing management standpoint, let's see, I've given you pretty much the information that you need on the slide with a few extra little things. Remember that the patient needs frequent rest periods following activity. Typically, when patients die, it's related to respiratory arrest following aspiration. So areas related to respiratory status and also prevention of aspiration are important things to think about. Think about the fact that cough, they have impaired ability to clear secretions, they have an increased risk of aspiration. We also want to think of from a pharmacological standpoint that we want to avoid medications that impair neuromuscular transmission. So some things like that you might think about would be things like sedatives or the aminoglycoside antibiotic. Their diet should be high protein, high fiber. We want them to have good sources of both potassium and calcium. We want to assess them for their ability to chew and swallow and watch closely for aspiration. Realize that we need to pace their activity and limit their exercise. It's important from a psychological standpoint to also be very reassuring and supportive whenever they're in either type of crisis, either myasthenic or cholinergic. I've given you some points here on long-term nursing management of the patient with myasthenia gravis. Remember that this is a chronic disease. Most patients are seen on an outpatient basis. And so since this is something that's going to be managed at home, patient education and family education is absolutely critical, particularly medication management. We need to make sure this patient is on a regular routine of taking their medications. We need the patient and the family to be very aware of side effects. Remember that the patient can actually go into cholinergic crisis. We focus on teaching the patient and the family the signs and symptoms of both myasthenic and cholinergic crises. They're also taught energy conservation. They're taught to have periods of rest throughout the day. To minimize aspiration, we want to teach them that meal times should coincide with peak medication effectiveness times. We want them to rest right before the meal so they've got the most muscle strength that they can possibly have. We may want them to eat soft foods that can be easily swallowed. There should be suction available in the home. When they eat, we want them to be upright with their neck slightly flexed forward to help to facilitate the swallowing, okay? We already talked a little bit about taping the eyelid or patching the eye if they can't close the eyelid, okay? And that is the end of this Collaborate.